This is just a question about future planning, I guess, for, I'm assuming it's going to become quite affordable relatively soon. I don't know about Pharmac funding and how long that might take, but I was thinking about clinics around the country with obviously funding issues and staffing issues, and how members of the panel see this rolling out in the future with lots more people on PrEP. Do you think it will end up that, for example, they come to a clinic or a GP, they get started, and then they get referred back to the GP for their regular 3 monthly checks? Or do you think it should remain in the realms of sexual health services? What are your opinions on that? Because we're going to have to be quite careful around resourcing, I guess.
So, can I maybe start? Thanks for that question, Nikki. I think, my personal feeling is that in general it's pretty straightforward, and that GPs with the appropriate training should be able to do it. And as you say, we don't have the funding or the manpower in publicly funded clinics to actually do this. Certainly we're trying to engage the GPs in New South Wales, even the ones who are not highly experienced with HIV medicine, in prescribing PrEP. And also interesting, another thing which I didn't mention in our talk was that they actually changed the legislation in New South Wales to allow nurses to dispense PrEP, because nurses are only allowed under our legislation to dispense standing order, and which is a single dose medication. I'm not sure what the situation is here, is that same? Under a doctor's, which a doctor has to then sign within 24 hours. But they changed the legislation to try and improve life for us when we had such a big demand for PrEP, allowing nurses, it still has to be prescribed by a doctor, but that can be done beforehand, and the nurse can actually dispense, give out the PrEP, which has also helped flow with the clinics as well.
Yeah, I'd agree with David that we wouldn't be able to cope with the demand, but at the moment we're focusing on trying to make sure we're following up all our PrEP participants. But I see in the future that once it becomes available, generic PrEP becomes available in New Zealand pharmacies, it will be much easier to prescribe. And what I envisage is that probably the sexual health clinics would focus on the most highest risk people who need a bit more expertise in sexual health to follow up, and that the majority of people are very straightforward, very health literate, that we might start them on it and then refer them back to their GP for follow-up, or we might just refer them straight off to a GP. And the work that Joe and the New Zealand AIDS Foundation have done has been a great start to all this, and I just think we just need to get more GPs upskilled in Auckland, and then we'll have a network of them around the city that will be good at it, who can do the necessary follow-up, because it's not rocket science, it's not that difficult, once you've had the training.
Yes, I think it'd be really good to have that training, but the evidence at the moment, when we look and see, well, when people do an STI screen, how many people get a proper STI screen when they go outside sexual health clinics? I think the evidence would be disappointing. How many people get good renal? So I think that's the idea that we should aim for, but I think we need to do this carefully. And probably what's happening at the moment, where people have selected GPs are going through this, I think it's a good idea, and that we should be encouraging multiple portals of access to this. And the other thing is the funding, because if it's going to cost $50 or so to access through their GP, some people are very reluctant to attend. They'd much rather go to a sexual health clinic. So this is where we're in, this is the funding thing. So I'm not sure. So we're going to have to think a lot around this. But at the moment, I suppose what we're doing is just getting it going and seeing how, as it unfolds, but doing as safe as we can.
I've had that exact discussion with Edward over the last few weeks, because similar to the Auckland experience, we just started PrEP in Christchurch, and similar to the Auckland experience, it seems to be being accessed by low-risk gay men rather than high risk men have sex with men in some cases. And the question is, do you decline those persons? But in the interests of not declining anyone PrEP at the moment, because we look with fear and trepidation at the 60% increased volume of your sexual health clinic, and particularly with the re-screening, repeat screening appointments, and there is going to have to become a triage system similar to what you've got. So it may be that, as Sunita said, sexual health clinics see only the riskiest people in the future, and that trained select group of general practitioners see the lower risk groups.
My question is, and I might have missed it, you're saying it, is there any evidence that this risky group that you're aiming for actually increase their risky behaviours? And since the STI group, the STIs found is already quite high in this group, I also see that this group should stay in sexual health clinics, contact tracing, multiple people to follow up on them. We know that's not well done in general practice. So is there any evidence of bacterial STIs and syphilis increasing and increased condomless sex?
So that's a really good question. I should point out that 60% increase that we saw was not just related to the routine screens. We actually found that each routine study visit for PrEP generated about 30%, so we had about an extra 30% additional consultations for management of STIs, for review of abnormal renal function, further investigations. So there is a lot more than just the standard visits. We have seen, interestingly, what we're seeing in terms of the STIs is gonorrhea is increasing exponentially, chlamydia is increasing exponentially, but syphilis is actually stable or going down because people are being tested every 3 months for syphilis, and we're catching asymptomatic early infections and treating them and removing them from the infectious pool. So Melbourne Sexual Health actually published a really good paper in Clinical Infectious Diseases recently, led by Eric Chow there, and they showed that more frequent testing was associated with a decline in syphilis diagnosis. So that's kind of interesting. Basically, that is reducing the population levels of syphilis. In regards to your other question, I can answer that through personal experience, not personal, my professional personal experience. When we did decline people PrEP. Some people we knew were just being told what to say by their friends, and we just had to take it on face value and say, you are eligible. I had a long-standing patient of mine who's on the SPANK study, and he came in for PrEP. Wasn't particularly high risk, but had a couple of casual regulars that he would have unprotected sex with. I said to him, look, you're not eligible, but you can import it genetically and pay for it. And of course, he imports it, his risk behaviour increases, and then a month later, he's eligible to go on the study. So yes, you know, like, that's a true story, and that kind of thing is going to happen.
Look, certainly in our study, that's one of the purposes of following behaviour change over time in the cohort. I think it's important to point out, though, that it's part of the eligibility criteria, and it's who we want into these early studies, which has been with already high risk and already high levels of incident and prevalent STIs. So that's actually really reassuring to see that profile in our sample. And I guess the question of, you know, how high can it go? Well, you know, there is evidence from overseas that some men change their behaviour, but I think the evidence is mixed. There's probably going to be a ceiling effect at some point. People still need to eat and sleep. But, you know, I think it really reinforces, you know, the other benefits that Dave and others have pointed out, which is this is a population who has traditionally been quite hard to recruit into clinical settings sometimes. This is something that they want, and we're attracting a group that's got high need. We're offering them regular screening, and there's potential for a really high amount of benefit as a consequence of enrolling them into the PrEP study that was probably unintended.
Thank you. I'll comment and a question, please. So comment first, just to echo what everyone else has already said, to acknowledge and thank the New Zealand AIDS Foundation for their advocacy in this area. And I think it's hard to overstate the importance of the change of that consent form. So thank you. So as Dave's alluded to with the Dave's alluded to needing to change legislation in New South Wales for nurses to dispense. What was a real block for us was the issue of importing and the provider risk. So thank you. So my question is just back to that nitty-gritty of the sheer volumes that you're describing, Dave. So fantastic that you've created capacity, but there must be people you're turning away. So have you introduced a triage system to say that the people that you can't see?
Yeah, we've always had a triage system actually for years in place. So our New South Wales Department of Health is very clear on who we are allowed to see and who we're not allowed to see. We've got our target populations, gay men, other people with HIV, sex workers, people who inject drugs, and Aboriginal people who will get in for anything, for STI screens. But in terms of people who will get in who are not in those groups, they have to have symptoms suggestive of an STI. So so everyone goes through a phone triage system. But recently we introduced, based on Sydney Sexual Health's experience of introducing an express kiosk. So we basically got a very quick throughput 15-minute appointment for asymptomatic screens. And because we've now got the capacity to have a much higher throughput for asymptomatic screens, they just do a quick online questionnaire at a kiosk. It's automatically uploaded into our system. They go into the blood collection room, they have bloods, they do their self-collected specimens, and they're out the door. So we've actually managed to move a whole load of people who are seeing, for taking up a lot more face-to-face clinician time into that, and that's freed up a lot more consultation time.
I just really wanted to say that we should not assume that all GPs or those in general practice are crap at doing these things, and if they are, they need to be educated, because a large part of New Zealand is rural, and I have background coming prior to Dunedin from Te Anau, and many have sex with men and bisexual men living in those communities, and unless they're going to privately import it, and they may not know how, I don't know how to do that, there will be prejudice against them. It will be difficult for them to access such a great initiative.
Speaking to that, I think we've watched the rollout of Vakira Pack, which is the Hep C treatment, done remarkably poorly really amongst primary care. I think the DHBs expected primary care would uptake it, but there was no funding available. And I personally had 3 patients who really wanted it, unable to afford the $150 for the 3 visits. And I had to send them into the DHB after doing the workup for them. And it's been really disappointing that such a great treatment which cures Hep C for people with Hep C 1A hasn't been able to be delivered to the high-risk population that have dual diagnosis and are passing it on. So if you are handing over to the GPs, be aware that primary care is really under a great deal of pressure, I think, in New Zealand. And we're looking at the moment at rurally, at primary care, looking at 40 to 50% of its workers being gone in the next decade. So I think where you've got it now sounds good.
So if we
Sorry, Helen, can I just mention about while I acknowledge there's a huge number of GPs who do STI screening very well, the data from our gay community periodic surveys, where we actually ask gay men about comprehensiveness of STI testing. So basically, have you had a throat swab, a bum swab, and a urine test? and a blood test, and we don't know if they've had syphilis or HIV, and under 50% of men who respond in those community surveys say that they've had that comprehensive testing. So obviously we've got a great focus on educating the general practitioners, and I totally acknowledge that it's the same things happening in Australia. You know, it's Medicare rebate freeze. They're to just survive and make a decent income. They have to charge, really, because you just can't possibly work if you're not charging extra. And obviously, clearly, that means that people are going to come to a free service, preferentially. You know, I think that's what we're seeing.
So in the interest of time, we might have to stop there, but I ask if you can all stay for the New Zealand Sexual Health Society AGM. I'd like you to thank all of our panel of fantastic speakers.